All right, and we're live. All right, welcome back to this week's lecture or discussion. Um, Again, my notes are in the corner, so just bear with me. Um, First off, reading the first article on the spotlight on athletic training based practice research networks. Boom, got it. Like I had so understood it for me, and I don't know how you guys felt about this, but the second one, that was like 6 of the 8 pages were graphs. I had like no idea what I was reading. Mostly because I think it's the conclusion that messed me up. Because I was like,
The two sentences?
yes. I, because I was just like, okay, like you threw all this information at me and you gave me 2 sentences, one being, hey, if you're working wrestling, be careful of skin conditions. Like for me, it didn't really flow. It didn't really make sense. Like, I'm not sure.
Yeah.
Yeah.
Yeah, the first one, like you said, yeah, I got a lot of notes out of it, and a lot of like just key points. And then the second one, maybe like two, the rest was just looking at the graphs. But other than that, nothing really just like popped out. But yeah, the first one I did like a lot, kind of pinpointed everything that we needed to do, like what we need to do in the future in order to like progress athletic training as a whole.
Yeah. Um, let's see. So, we talked about it briefly, and it's kind of hard for us not to talk about our discussion and save all of it because we see each other all the time, and we have to clarify within each other what we think we read. But I think the main gist that I got from a lot of this was documentation and why it is important to clinicians, and why it matters and stuff like that. So the first biggest takeaway I got from all of this is Dina. Like that was the first example I thought of because it's like make sure
Yep.
we're documenting it, make sure we're doing X, Y, Z, make sure we're doing all of this stuff. Um, and we've all sat in Dina's office when she's like, hold on, I have to put this in, and it's fiscal numbers, whatever that means, and it's October, so I have to run these numbers again, and I basically have to show the city why I'm saving them so much money.
Yep.
So this was that was the biggest one that I can think of about here she is, and she's not even going through the PBRN network networks or anything. Like this is just for her to validate to her boss why she's needed. And
Yep.
so I wonder if she decided to participate in these networks, how much this could affect and help out the need for more athletic trainers in the non-traditional settings like
Yep.
safety.
Yeah, and I think I was thinking like Dina as well, especially for this, like the PBRNs is a lot of it. The non-traditional setting has to do, and that's just to validate that their job is necessary and is needed for whatever company they work for. And I think that's probably the best setting for this to be in, especially for the non-traditional setting, because they're growing, they're showing up and saying like, "Hey, my job is important. I can help you save money, and we can work together as a team to move on and help not only like your workers and everything, but just keep them moving."
Yeah. I also thought about in the physician setting. I know a couple of years ago, Molly McNeil, one of the graduates of the Emory residency program, she gave a talk about how she justifies her position as a physician extender for an orthopedic surgeon, and basically she helps how she can help seeing patients, saving time in the operating room, stuff like that. So that also came to mind with that.
Most injuries of patients who present to athletic training facility did not result in time off participation. And I think what better way to show that because they come to see me does not mean I'm taken out. Because they come to see me does not mean that I have to do anything. Sorry, Josh, am I not talking loud enough?
I don't know. She seems a little bit low. I don't know if it's just me.
You got louder as you went on, but at first it was like you were underwater kind of thing.
You're good. Continue.
Yeah, I just found that really interesting that it did not result from time loss, and they pointed it out twice. It was two statistics from two different sources that yes, just because they come to us does not mean time loss, and that also kind of points out to our job that yes, like we don't take people out, we keep people in, and that's the point.
Yeah.
So yeah.
And that brings up a good point. So in the first article, they say, um, rather than focus exclusively on the role that ATs play in restoring a patient to a specific level of activity or participation, we may need to shift attention to include our role in facilitating, maintaining, and enabling activity and participation. That's probably what you're talking about. If not, there's another way that they said it. But it reminds me of my internship experience with the professional team. Of you really can't afford an unhealthy roster. Like they always want to be unhealthy or have 100% healthy roster. A, because it's their job, and then two, because this is they play to win. It's a sport still, and so that was pretty interesting to me because I made the comment always strive to have a healthy roster. But if we're just working on facilitating, maintaining, then again it validates hey, we're here and there you still have 100% healthy roster because they're seeing me and we're maintaining and we're helping to decrease any pain or increase strength, whatever, so on. But this is why you need us, because you have anyone to choose from on the roster because of us, kind of thing.
Okay, another good point. Another good point I found was that they talked about patient-reported outcomes and how important, how imperative it is, especially for the AT PBRN and the nation. Both of those are really important so that you're not only seeing my clinical outcomes, but you're also seeing how my patients feel about my outcomes and how that kind of sways us and that helps us show our role more. And I think these past 2 weeks have been about how can we prove ourselves? How can we say that we are athletic trainers? How are we saying that we're helping? What are we doing to help? And these are great ways. I think is basically what they're trying to point out. It's a pro is an awesome way to show that's how we're helping. That's what we're doing. This is what we're doing. This is how we're helping, and so on. So, yeah.
So I'm kind of looking at the second article, and I wrote a note. So it was to calculate the relative workload for each sport, the AMCIA guidelines recommend multiplying the injury risk based on multiple injury surveillance data with the average number of treatments per injury. So my biggest takeaway, and you guys can clarify if I'm wrong, but to me that meant, okay, well, we can use this to validate why we need more staff here. Just because you're a smaller school or you're a Division III school or something like that, smaller high school, doesn't mean that you don't deserve to have proper staffing. So I was immediately my first thought was man, if we signed up for that at TOU and we did the work, and we used the EMR and we participated in all this stuff, then could this help us validate to Bill Miller, hey, we need 3 people on staff. Let's try 3 people on staff plus our 2 GAs, which will eventually go away. But hey, we need more people because we're having trouble even with the program and even with the 2. So that was my biggest thing on that.
I feel like that could also be justification, the fact that GAs are going away, because the GAs do a lot for us here. So the justification of this position is going away in the future, we won't have students working for us who are certified to kind of cover these events that we're not necessarily all the time there for. So that would also be something to use to justify the fact that we need.
Yeah, I also like the points where it brings up how not only for new workers and new athletic trainers to be on the team, but also informing the coaches and why we're not always at their practice or why we're always not there. It kind of just helps us validate that, okay, we're more focused on the high risk teams more than the non-high risk teams. Yes, your sport is important and everything, but at this point they need me more at this sport than your sport. So it kind of just helps delineate where we need to be specifically. And that's kind of a good use and why we need to have this evidence that we need to collect.
And I feel like that point has came up a lot. come up a lot in the past few years since, like, we've lost students, the program has changed, and we don't have as many students right now as we used to, and things like that, of why we can't cover tennis, why we have a GA on volleyball and not a GA and a student on volleyball, why we have like no cross country athletic trainer, why we have no track athletic trainer, and that type of stuff. And so this kind of points to them, well, like, your sport is important, and I do see your patients, but I see more of these patients than I do of any other patient. And that I'm pretty sure Matt and Amy had to go through that to justify, like, oh, why did football get 7 athletic trainers and we only have 0, and like all this other stuff. So I think that is important to point out.
Yeah. Which it's hard because you can show a coach numbers and you can show figures, but at the end of the day, they're still going to care about why their kids aren't getting taken care of, or, yeah, can't you just donate one? Like, what's one to the GA? Which is kind of difficult. But I think it's harder to deny numbers than it is to be like, well, I see about 10 patients, or I see more patients than I do your tennis players or cheerleaders or whatever it may be. So when you have that number and those figures, it's easier to be like, I hear what you're saying. You are important, but the numbers don't lie, man. The proof is in the pudding, kind of thing. So it's a good idea. And I talked to Matt about the whole network thing in general, because they use an EMR, right? And they go from there, and because you use their EMR, and Matt said he looked into it in the past. So because you use their EMR or whatever, it's free, but then they're allowed to pull that data out and use it for studies. So we had talked to Matt, or I asked Matt, like, hey, like, why haven't we done it, kind of thing? Mostly because I don't think we have poor documentation. Like, I think for the most part, our documentation is pretty thorough because of like the standard Matt wants it to be. So I asked him, like, hey, why are we not doing this? Like, they can use our stuff. And then even just aside from research, like, we can use it a lot more. And he didn't turn it down. He just said it was something that he looked at in the past, and it just hasn't really come up again until I asked him today and was like, hey, why are we not doing this? So yeah.
Okay. I kind of did not. I'm gonna be honest. I didn't really like the second article. I can't speak. The second article, okay. I didn't like it that much because, like, I feel like what it stated was stuff that we already know, from being in a KD accredited program and stuff like that. Like, all athletic trainers at this point should have gone, or most of them have gone through a KD accredited program in order to get their licensure and get their BOC certification and all that other good stuff. But it like pointed out, oh, if you're a wrestler, if you have a wrestling, you need to be worried about skin infections. You learned that in school. Why do you not already know that? And I just kind of didn't like it. That's just me talking about it in general. But
or like, these are the most popular injuries that we're seeing. Like, yeah, it's about the same here too. I kind of already knew that.
Yeah. The only like kind of takeaway I did get from the second one is just how I could use that information in the long haul. It kind of, like we said, it can help you focus your intention on what sports to look out for or to cover, and then, but also it could help you in to look out for the things specifically for that sport. So say 1 year, like, all of a sudden there's a whole bunch of hamstring and quad strain in soccer. Okay, what happened in that year that's different from the rest of the years? So it kind of gives you some of that try to clarification of, okay, did we do something different this year? Like, what's going on? And then we can use that for next year. It's like, okay, let's do this and this. Let's do some preventative measures in the beginning so we don't get to that point again where we have so many strains of quads and hamstring strains. So it kind of, I guess you can use some of the information that you gather for the future, for future tense, so you can just help be safe and be cautious for the following years.
Yeah. And that's something like we as a cohort can already do. Like we can basically generate those reports on sportswear or on school whatever on sportswear like by teams like at the end of the year maybe it's like our reflective thing of like hey like I had football Derica me and Britt had football Derica has soccer Josh has soccer let's like look at just a breakdown of all the injuries and let's look at okay, what's the percentage of ankle injuries or knee injuries and stuff like that, or chronic long term? And maybe that's something that we carry forward, like, okay, so we noticed in soccer, Josh, like you mentioned, like, hey, there's an excess of hamstring muscles or hamstring sprains. Maybe in the future we do like, okay, let's talk to Eddie. Maybe we tell Eddie, bring it to his attention, and we say like, hey, Eddie, this year we're gonna try like that they all do some sort of like preventative exercises for hamstring. So like because your injury rates were so high last year, let's get you to a healthy roster by doing XYZ. Which honestly sounds really cool. I'd like to retake my study and I'm gonna read this IRB because that sounds awesome until I actually start research and then I'm probably gonna hate it. But I think that's like really good and I think it's feasible to do at smaller schools like ours. You know, um, I don't know.
Or I was thinking, like, also, if you look in the past and you see what specifically different injuries you were dealing with in that past year, you could use that. Or I know we just had like an increase in our budget, and we were thinking, like, oh, what all new like stuff do we need for the clinic, like research wise or modality wise? Like, you could think about that if you're at a place that has like a budget for the new year, like what new rehab equipment that you need, like we got a body blade this year. We didn't have one before, but now I can use that for my upper extremity injuries.
I think it's on loan still. It's loaned to us, but besides the fact, you're so right.
But yeah, just using it like that. That could be another thing.
Yeah, I think you could also use that info to like you said, the preventative program and like rehab planning. But then you could also use it for job justification.
Yeah.
Yep.
Like if it's low, or say I implemented the new program and now my injuries have decreased significantly.
Yeah.
You're welcome. You know, like that type of stuff. So
Yeah, I'm trying to think of like so we know kind of how we would implement it in like our setting here. But I guess what's another other discussion question? Something about how we could take it further. So yeah, we can generate reports and look from there. But like, I guess using it at high school is probably my next biggest thing. Like, again, job justification of like we need another AT or I don't know, whatever the case may be. I guess preventative stuff again, but
I guess if it was like an easy preventative thing, like, oh, here's a couple therapeutic exercises that you could incorporate in the warm up, or like a stretching program or stuff like that, and you see how the injury numbers are in the future because of that, then I guess I don't know what you would get out of that other than just like satisfaction in yourself and being a clinician. But yeah, like job justification, showing the coaches that you're helping, because a lot of the times if a patient comes in, not so much anymore, times are changing, but in the past, if you're coming into the clinic like, oh, you're hurt all the time, you're weak, you like there's always going to be another player to take their spot kind of thing. So like as time changed, maybe being like, hey, coaches, like this is what we're doing so that we don't get to the point where you have an unhealthy roster.
Yeah.
You don't have to deal with the awkward situation of the patients not necessarily being scared of their coaches, but being scared to be hurt because they don't want the repercussions of that, of being taken out.
Yeah, and I think that's important in general. That's really big, especially in the pros. It really sucked because the athletic training room was on the way to the cafeteria. So many people, so many coaches would walk through all the time, and the players would be like, "Oh no, I'm fine." Like the coaches stop and talk to them, like, "Oh, how you feeling?" Yeah. "Oh, I'm great, coach. I'm just in here for a little loving, blah blah blah." And I'm like, "You hurt." Like But at the same time, we all hate that coach mentality where it's like, he's weak. I'm like, no, he's not weak. He's just in pain. And I think that's an important justification to have to make and to try to differentiate between.
Yeah. Or just back again on the coaching mentality that, oh, they didn't do the things they were supposed to, or they weren't conditioning properly, or whatever. And sometimes it's hard to avoid that. Like, there are certain injuries, like most injuries are inevitable. Like, you just don't wake up one day and you're like, today I'm gonna feel like my ACL is gonna tear. Like, no one wakes up thinking that, you know. So we can't say like, okay, there's a higher prevalency with these injuries and these sports, so we're going to do a lot of like preventative for that. But I think a good start would be, like I said, like generating those reports and seeing like what percentage of what. Like, maybe we don't just limit just football to making sure they're on doing their rehab all the time, or we look at like, hey, we see a lot of AC joint stuff like at football. What do we have to do, and what do we have to look at to be like, let's also do like some preventative stuff there. So like, you do your ankles and you do, you know. And the second thing that's pretty hard, I think, about implementing all these is like, yeah, I think these are great ideas about implementing these preventative exercises and stuff, but it is so hard to keep X amount of players accountable when there's like one of you. And you can ask, and like sometimes I just ask just to ask because I know they definitely didn't do their rehab, like their ankle, you know. And so I don't know, that's the difficult part. And I think with any study and anywhere athletic training starts or athletic trainers start with certain research projects, there's always those limitations, you know. So.
Yeah, I think with that point, you have to have a good relationship with your coach, because you can then have them incorporate mini band routines into practice. You can have them do all these things that'll basically help you out and help them out. Like, you have to show them that this is a mutual relationship. Wait, is it a symbiotic relationship? Is that what it's called? Or something like that. Either way.
Mutual.
You
Yes.
both have each other.
Yes.
That's like 5th grade science, so.
But you know, we both gain something in this relationship of, if you incorporate these preventative exercises into practice, you have less injuries. They have to come see me less. You have a healthy roster, and it all works out for the good of both of us in the end.
Yeah.
Another thing you can collect in terms of evidence is not only the different kinds of injuries, but how long you can expect a patient to be out for a specific injury. Because you know that's always the first question from both the patient and the coach is, okay, you've evaluated them, this was your diagnosis, now what? How long are they going to be out for? What do they need to do? Can we keep them as tolerated? If you have evidence like that states like, oh, they were out for this long, limited for this long, as tolerated for this long, or this is the average, then you can kind of give your patient and your coach a better idea of that. That can also help a lot with plan of care stuff.
I think that's a super good point about, because really we're like, oh, well, you can expect to be out for 3 weeks. And maybe it's just like this team that we have this year in Derica, maybe it was different. But I feel like now they're just like, yeah, okay, fine, like I'm out. Like, I know I'm going to be out. But how long till I can go back on the field and do functional stuff? And how long can I, you know, like, so the whole drafting out, like, typically you're out for this long with rehab inside, then limited doing functional stuff, and then as tolerated where we throw you into half practice, full practice, stuff like that. I'm just not sure like how feasible that is, because then that takes into account like everyone's injury is different. While we may think like, oh, dude, you just have like an ATF sprain, you'll be fine, we'll see you in like 2 weeks, and then turns out 2 weeks is hit, and we're like, why are you still not progressing? And that's the hard part, is like in our head we're like, okay, textbook says this is a timeline, and typically on average that is, but then we get those handful of patients that will start, like if our pool of ankles is like this big, we start to get those that aren't matching the typical timeline, and it's like, what's going on here kind of thing. But I like that idea of like, I wish we could break down like, this is typically the time span of each stage that we're in kind of thing.
Yeah, I feel like it would definitely be more feasible or more reliable, I guess, in like a setting with a bigger population to deal with, like a D1 school or Not even really a professional team because that's still just one team, but bigger place.
Yeah.
Yeah.
I think of that though, like how, like for D1 schools, because I'm like, yeah, but some of them never see the field or never really practice. So like, but there's, I don't know, there's got to be a way to do that. I'd be interested, and maybe that's where we talk to Matt and we're like, hey, got an idea.
Or maybe, I'm not sure how many
Yeah.
patients Dina sees in like a year, but something.
Yeah. Derica, do we cover everything? Or am I missing something? Any last minute talking points?
Um.
I don't think so. I think we kind of got everything.
Yeah.
I think we hit 30 minutes, yeah.
Yeah, we did.
Well, yeah, but I was just making sure we had like all our questions.
Yeah, we have 10 minutes remaining. So we hit it.
All right. Well, I guess we'll get some feedback on this, but again, I thought they were really good. A lot easier to do these once, like since we're in immersive and we can see all of this. All right, guys. See you later.
Bye.
Nice talk.
Bye.
Hey, Josh.